the me part is kinda irrelevant here. So this is a 21-year-old male patient. It's a right knee, and it says nothing on the clinical history. It says nothing on the doctor's order. It's just a good old guesswork scan. So let's take a educated guess and just try to figure out why this patient has been through this scan. So we have the patella, the femoral and the tibial extremities. I have seen already a ruptured posterior horn medial meniscus right there. So this is a horizontal lesion right there. It goes all the way to the tibial articular surface of that meniscus, and we also have a tear of the anterior cruciate ligament right there. It's gone. It's completely ruptured. So this is that classic anterior cruciate plus medial meniscus tear, which leads to surgery. It's a classic surgical case. The lateral meniscus is fine. The posterior meniscus, the medial meniscus isn't. We have a Baker's cyst right there. We also have a mild articular effusion. Patellar and quadriceps tendons are fine. I suppose there might be some kind of chondral disease right there. It's kind of shaky and noisy. Can't really tell for sure. But let's go for a coronal. Hey, I'm sorry. I'm just a bit sleepy. I did have a fairly good night of sleep, but for some reason I'm still sleepy. Maybe I'm just lazy, or maybe I should have kept myself on my diet during the weekend, which I didn't, and it just breaks me apart on Mondays when I eat crap on the weekend. Might be just that. So indeed, there is a horizontal tear right there on the posterior horn of the medial meniscus, and it indeed reaches the tibial surface, the tibial site, the tibial articular surface right there. And indeed, there is a rupture of the anterior cruciate ligament right there. Let's just go for the axial PD with fast saturation, so we can properly tell if there is any patellar cartilage erosion, fissure, fibrillation. This is a type 1 Wieberg classification patella, which is fine. Indeed, we have a mild articular effusion, and of course we can tell there is a ruptured anterior cruciate ligament. This is the posterior. The posterior is fine, but the Baker's cyst is right here also. There isn't a lot of bone edema. I can't really say there is bone contusions, nor major signs of soft tissue edema. So I can say this patient has a chronic lesion. It has been through some time of post-rupture treatment, maybe some physical therapy, and I seen this knee, so it's really not swelling at all. It's just this might even be a pre-surgical assessment. They usually treat ruptured anterior cruciate ligaments clinically, and then they do surgery when it's just like this. There is no residual edema, not a very profuse effusion, when it's just like it's not a really inflamed joint. So this surgery can go much easier than if it's an acute lesion right there. So this is ruptured. It's clearly ruptured right there. This isn't properly positioned, but it usually isn't. So we just get used to it. So it's a posterior horn medial meniscus tear and a anterior cruciate ligament tear, a Baker's cyst, and a small articular effusion. No chondral lesions, no hypertrophy, no soft tissue edema. So let's just write it down.